Hello, everyone. Thank you for coming. Welcome to NADO's 38th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments in the chat and questions in the Q&A. We hope you will take advantage of this opportunity to engage with our speakers and attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in our daily drawings. Now, let me turn the stage over to Norm Thurston, NADO's Executive Director. Norm, the stage is yours.
Thank you, Erica. It's a pleasure to be with you again for this special session on advancing health equity. I'm excited to be with you today for this one. We want to recognize our sponsor for this session. The session is entitled Advancing Health Equity Utilizing Data on Behavioral Health, Gender, and Social Determinants of Health, and was organized and will be moderated by Kristen Battis from HSRI. Today's session is sponsored by Barry Dunn. And Barry Dunn has asked that we read the following statement. Barry Dunn is pleased to sponsor this session. Using data to address health equity is a critical issue of our time. Barry Dunn's Healthcare Analytics Practice Group integrates economics, actuarial science, data management, and analytic services to help healthcare leaders make informed decisions. Our approach emphasizes collaboration, engaging clients to fully understand their objectives and meet their specific business and analytic needs. Our team is pleased to support health data organizations as they explore solutions for utilizing survey and claims data on behavioral health, gender, and social determinants of health. So again, thank you to Barry Dunn for sponsoring the session. I'm now going to bring on stage our moderator, Kristen Battis from HSRI. Kristen, I'm going to turn the time over to you and we'll go ahead and get started.
Thank you, Norm, and thank you everybody for joining us today. It's great to have you here. As Norm said, I'm Kristen Battis, and I'm a data scientist at Human Services Research Institute, and I'm very excited to be the moderator for this session, which has a great lineup of 3 presentations for you. As a reminder to folks joining us, you can use the chat feature to leave comments or ask questions during presentations, and there will also be an opportunity after our final presenter for a larger Q&A, so keep that in mind as you think about what you might want to learn more about. Our first set of presenters are Simon Casson, a data and economic analyst at the Washington State Office of the Insurance Commissioner, and Amy Kinner, the Director of Health Analytics at OnPoint Health Data. Please note that the full bios of each presenter are available in the links on screen below the video panel. Simon and Amy are going to present a study of behavioral health utilization in Washington State, and I'll turn it over to Simon and Amy now.
Hello, my name is Simon Casson. I'm the Data and Economic Analyst at the Washington Office of the Insurance Commissioner. I'm here co-presenting with Amy Kinner from OnPoint Health Data. And today we're going to be talking about work that the OIC has been undertaking to look at the availability and access to behavioral health services in Washington. Key components of this work have been 2 studies that we've undertaken looking at the behavioral health services claims. So I'm going to be giving some background on OIC's work and the first baseline study done by OnPoint, and then Amy will discuss our most recent ongoing study. So back in 2018, OIC received 2 federal grants to see if state-regulated health insurers are offering comprehensive and affordable access to mental health services and treatment for substance use disorder. So this grant has 2 cycles. The first cycle, which occurred from 2018 to 2020, has 3 components associated with it. There's the broad market scan of health carriers, and has collected information including procedures, policies, and benefit design. And then we also did a second, more targeted market scan, which was based on the results of that first scan. And then finally, we did an initial ABCD claims analysis with OnPoint, referred to as the baseline study. And this really looked at behavioral health service utilization in Washington. And then the second cycle of this federal grant, which is currently ongoing, includes creating consumer and provider education materials, market conduct activities related to the 2 market scans performed in the first cycle, and then also a second APCD claims analysis performed by OnPoint, and Amy will dive into more detail on that ongoing work shortly. So this baseline behavioral health crisis study really just looked at how enrollees in commercial health plans use behavioral health services with a real focus on crisis response services. So the study used claims data from the Washington APCD as well as a separately requested denied claims data, which was merged with the APCD claims. So most carriers do not submit SUD claims to the APCD, and many do not submit robust denied claims. So this supplemental denied claims data set enabled a more thorough analysis of mental health, substance use disorder, and suicide self-harm diagnoses with a focus on denied claims. And then, as mentioned, the study serves as a baseline. So this baseline study looked at claims from October 2017 through September of 2018, and really looked at those who were enrolled in a fully insured commercial health plan and were Washington residents under the age of 65. For diagnoses, it was limited to those with a primary diagnosis of mental health, substance use disorder, or suicide, self-harm, and it does not capture services where enrollees may have paid out of pocket without actually billing the health plan, which is a relatively common occurrence. And then key things that were looked at, key metrics as a part of the study, broken out by service type with the total number of eligible members, the number of eligible members who had a given service during the year, the number of services, both denied and paid during the year, and then also looking at denied claims. And just some key findings from this work, 12.4% of individuals had at least one claim during the year for mental health. 1.1% of individuals had claims for substance use disorder treatment. Looking at denials were highest for substance use disorder claims when compared to both mental health and suicide self-harm. Looking at the results by age, OnPoint found that the young adults actually had higher denial rates. And then finally, as we also saw in the non-behavioral health claims, out-of-network behavioral health claims were more likely to be denied when compared to in-network. And I'll hand it over to Amy to talk about the follow-up study.
Thanks, Simon. So for the follow-up study, we did not have the supplemental substance use disorder denied claims data. So we really focused on what was available in the Washington APCD without an extra data call. And the focus was really on trends over time, pre-pandemic to current. So trying to see how things have changed during that period of time, looking at percent of members with conditions, utilization and out-of-network use, but also cost of care, price, and total cost of care. This work is ongoing, so we'll provide some preliminary results today, but a lot is still to come. We are also doing a focus on rural-urban stratifications, and we'll show some of that today using the rural-urban commuting area codes. So as Simon mentioned, the substance use disorder claims are not consistently submitted by commercial submitters in Washington. Some of the key large commercial submitters do not submit those claims. So without that supplemental data, we decided to limit to the mental health population because it is not necessarily possible to get a comprehensive glimpse of substance use disorder analysis in Washington. So the key methods, we again limited to a similar population. We looked at 2017 through 2022, and we'll show some trends in this presentation. We did an analysis at the member level, so looking at patients not just with one claim per year, but two or more mental health diagnoses in claims during the past 2 years. And we also did a claims analysis that looks at in and out of network claims limited to a primary diagnosis of mental health. So here's a few results from the initial part of the study. We found that there was a significant upward trend of mental health conditions between 2017 and 2022. And you can see that that accelerated during the pandemic, but the trend was upward before the pandemic. We also looked at serious mental illnesses and found that those increased as well during this time period. The driving factor behind the rise in mental health conditions appears to be anxiety disorders, which nearly doubled from 4.4% to 8% between 2017 and 2022. However, many of the other conditions also did increase during this time. We broke that out by various rural-urban categories: small town or rural, suburban, large rural, and urban core, and looked at 2017 to 2022 rates. And as you can see, there was some variation between treatment and diagnoses of mental health conditions in these various areas, but all increased significantly between 2017 and 2022. We also looked at the claims themselves with a primary diagnosis of mental health, and we looked at in and out of network claims. And we found that in both years, out of network utilization for mental health claims was significantly higher than for non-mental health claims. 7% of mental health claims were billed to out of network providers, compared with 3% of non-mental health claims in 2022. We saw some decrease between 2017 and 2022 for mental health claims being billed out of network, but they still remain quite a bit higher, indicating perhaps there are some network availability issues for mental health claims. We broke out non-mental health versus mental health claims percent in and out of network by the different rural-urban categories. And we saw that for every category, the mental health medical claims had a higher percent out of network than the non-mental health medical claims. So to summarize the two studies that we have been working on so far, and more to come because we're still finishing up our second study, but to summarize what we found so far, denied claims are higher for substance use disorder than mental health claims. Out-of-network claims were more likely to be denied. In terms of mental health trends, we saw that the percentage of members with mental health diagnoses has been increasing significantly over time, and that's largely driven by anxiety. Diagnoses increased both in rural and urban areas and everywhere in between. And compared with other medical claims, mental health claims are more likely to be billed by out-of-network providers. So thank you so much for listening to our presentation, and we're excited to answer some questions.
All right, thank you, Amy and Simon, for sharing your findings from your two behavioral health studies in Washington. I had one question to start. How did you determine your list of diagnosis codes for identifying behavioral health claims? Did you use HRQ's clinical classification software, or did you use some other methodology?
Yeah, so I can take that question. We used SAMHSA produces reporting and on mental health diagnoses, and in that reporting they have identified different classifications and the ICD-10 codes for those classifications. So we basically took their appendix of their study and made it into a value set and used that to identify the different classifications.
Thank you. We have a question from the audience. Do you have suggestions for how 42 CFR Part 2 requirements could be adjusted to improve data completeness needed for this type of analysis? And that's related to the SUD claims study.
Sure. Great question, Norm. And I think you might have asked this question in another session too. One thing that's really interesting is that we've looked at this in Washington, and we actually had a really unique opportunity here because we had done that data call a few years back. So we had all of the SUD claims, and then we also had our extract that with the normal, APCD claims. So we were able to make that comparison between the two databases, so we could actually see the delta of what we were missing, which was kind of an exciting opportunity. And what we found was that it's submitter by submitter. The public payers are submitting SUD claims, so Medicaid, Medicare, and a lot of the commercial payers are also submitting those. So it's really, and it's really interesting that only a few payers weren't in the Washington market. Those happen to be some of the large payers. We've looked at this in other states, and actually, just did a quick look in Vermont, for example, and there may be a couple payers that aren't submitting it, but in general, the bigger payers are. So the data there is a lot more comprehensive. So really, it's payer by payer. So what is the how to get the data completeness improved? It seems like people are interpreting that law differently. So does the law need to be changed, or do we need to find another way to get payers to submit it?
Thanks, Amy. I had a question, Simon, for you. In the baseline study, were there any variations in results by geography?
Yeah, there absolutely were. I think so. Amy and On Point looked at this at the county level and did note that there were several counties that had higher behavioral health denial rates. And then these counties did tend to be more rural. However, I don't, rurality was not a clear-cut indicator for denials. But there certainly was a breakout by geography at the county level, and we did run into issues with some suppressions that when you're breaking it out at that granular of a level. But
thank you. And for both of you, have you looked into how Washington compares to the nation as a whole or to other similar states as Washington?
Yeah, I can start with that, Amy. So at least the baseline study did compare results to national trends. But there's a few caveats to be made around this comparison. The comparison was made to the results from the SAMHSA National Survey on Drug Use and Health, which I believe captures the entire U.S. population, 12 and older, who's uninstitutionalized. I believe that's the population captured there. So, noting that the baseline study is really only looking at those commercially fully insured individuals, and there's notably excluding Medicaid, and there's likely to be differences in behavioral health disorder prevalence across those different populations. And with that caveat in mind, the baseline study did note that 12.4% of individuals had at least one claim during the year for mental health, and where the nationwide average was 20.6% reporting of a mental illness. So I think obviously lower than that national level of folks indicating they have a mental illness. So really just indicating that there is most likely an unmet need for these services in Washington, likely.
All right, thank you. One more question for you, Amy. Let's see. How did you determine whether a claim is out of network?
Yeah, another good question. So in Washington, as part of the data submission guide, the state is collecting a flag on in and out of network. So we actually have that data in the APCD, and it's really helpful to use. We've used it for this project. We've used it for looking at surprise billing, also with Simon's team to look at the impact of that. So definitely a great field to have.
Excellent. All right. I don't see any other questions from the audience. So thank you again. We appreciate your time and the information that you shared with us, and we'll see you back here at the end of the session. Next up is Miga Jha, a healthcare reporting analyst with Civic, the Center for Improving Value in Healthcare, who will be presenting on gender-affirming care in Colorado, considering nuance in politically charged data releases. And I'll turn it over to Miga now.
Good afternoon, everybody. I am Miga Jha, Healthcare Data Analyst at Center for Improving Value in Healthcare, or CIVIC. I am here to present and talk about one of my projects, Gender Affirming Care in Colorado, considering nuance in politically charged data releases. So CIVIC is an administrator and custodian of Colorado All-Payer Claims Database, or COAPCD. Here is a brief overview of what's included in COAPCD: medical, pharmacy, and dental claims, data from 2013 to 2022, totaling more than 1 billion claims, around 14 commercial payers, plus Medicare and Medicaid. We estimate our database covers more than 70% of covered lives in Colorado for medical claims. What is not included in CAPCD are federal programs such as VA, TRICARE, Indian Health Services, ERISA-based self-insured employers, and uninsured self-pay claims. How does Civic serve the community using CAPCD is through public data as well as non-public data. Public data incorporates our interactive reports and publication on our website, which is easily available for anyone to use and download the data. Non-public data are usually custom projects based on specific needs of customers. Some of our focus area are community engagement, advanced care planning, palliative care, and research and evaluation services. So the background of this project, gender affirming care, it is typically refers to care received by a person whose assigned sex at birth does not match gender identity. This can include social, economic, emotional, behavioral, and medical care, and encompasses anything from using a person's pronouns to social support to gender confirmation surgery. Gender affirming care is common among gender diverse, transgender, and non binary individuals or TGDNB individuals. Some background about this project. In 2017 being an important year when Colorado Department of Healthcare Policy and Financing Medical Services Board passed a statute for comprehensive Medicaid transition-related care benefit. In October of 2021, Colorado became first state to require comprehensive gender-affirming care as a part minimum or benchmark for healthcare plans sold on individual and small group markets. And commercial payers are required to comply to this by 2023. The goal of this project's analysis was to understand the utilization of such gender-affirming care services in Colorado over time by different health insurance payers. So initially, Civic engaged with multiple community partners to ensure the perspective of LGBTQ advocates was heard and considered in release of the analysis. Analysts consulted with Colorado advocacy organization One Colorado to make sure all concerns or considerations were taken into account, and data was released in accordance with the standards of the community. Additional resources which were used or where we had done some of our literature review were One Colorado's Closing the Gap report, the Trevor Project, and Human Rights Campaign Gender Affirming Care resources. So what's included in the methodology? It includes medical claims of all Coloradans from 2016 to 2021. All types of claims were included: professional, inpatient, outpatient, having ICD-10 codes of gender affirming care, which were mostly F66.X. ICD-10 codes included in our COAPCD were about 10 to 11 of the codes. Please note that there are concerns that ICD-10 codes for such care are narrow and create barriers for those seeking care. The payers which were included in the project were commercial and Medicaid. And the population of the project was divided into two subgroups: 17 years or younger, and young adults, which were 18 years to 24 years. Analysis included were volumes of claim per year, rate of distinct people per 100,000 covered lives in COAPCD, median allowed amount per payer per year, age 17 years or younger, or age 18 to 24, and race and ethnicity was also looked into, where we included all years data. So the findings. This is the finding about average allowed amount by payer. The x-axis shows us year, while y-axis shows average allowed amount per service. What is a service? Service is a COAPCD member having a claim with a distinct provider on a specific date of service. As you can see, since 2017, average cost per service for Medicaid has remained around $300 to $350 per service, while we see an upward trend for commercial payers. which increases from 570 to about 662. Moving forward, these are the trends of claim volumes by age and payer. As you can see on the left, Medicaid, there's a consistent increase. Commercial shows the same trend, but the amount of uh, member count, the claim counts were considerably lesser. Among usage among adults, young adults is higher, as you can see. The assumption here is that they become independent at this age and utilize more of such services. Race and ethnicity data. Since most of this data is voluntary, we see quite a bit of variation in against Colorado's census data. Although WISE has highest percentage of 38 here, but they are quite low compared to 61% in general population. Secondly, as you can see, non-Hispanic or Latino unknown race and unknown race and ethnicity constitutes to about 27 and 5%, which is the second largest group here. Data is collected for these race and ethnicity through the guidelines given by Office of Management and Budget, or OMB. It's based on self-identification. As you can see, the percentage among Asian and Blacks are also low compared to Colorado census data. Findings and insight. The number of individuals receiving gender-affirming care in Colorado rose from 300% from 2016 to 2021. While this was a significant rise, but it only represented 0.01% of people covered in Medicaid and commercial. Increase attribute to the change in coverage requirement, not an increase in the number of people needing care, but rather than increase in the number of people getting access to these essential services through their health insurance for the first time. Impact and the data outreach, lot of public interest in this data. As you can see, more than 100 plus data downloads from our website. And there was media total outreach of about 602,000. There was also a public news service about reports finds Colorado a leader in access to gender affirming care. Challenges for these projects were quite a few, such as data sensitivity and compliance with data release, misconstrued data sharing and communicating, which codes to incorporate in such a study. As you can see, it's very narrow. There were also quite a bit of lessons learned, like community engagement with different partners, lot of literature review and source review, use of external resources to contextualize data which was shared, and other limitations in scope and proper utilization of F64 codes. So, and that's all, folks. If you have questions or feedback, please feel free to reach out to me at mjha@civic.org. You can also stay connected with Civic on Facebook, LinkedIn, and Twitter by joining our email list at www.civic.org. Thanks so much for your time and interest. Hope to hear soon from you guys. Any questions?
Thank you, Mika, for that informative presentation on gender affirming care in Colorado. It looks like we have a few audience questions, so I'll start with those. From Norm, you mentioned that race and ethnicity data are self-reported. Do you think improving the quality of that field will change your understanding or allow you to answer different questions?
That's a good question, Norm. Yes, and we did look into race and ethnicity, and this has been an ongoing struggle for such kind of reports where we don't tend to see too many people identify themselves. And this can be taken into account that such kind of services of care was not readily available until a few years ago. And although Colorado being the pioneer in this among all the states, still there is the volume and the claim counts or the providers providing such services are so low. Definitely race and ethnicity data collection, if it is done properly, we would have a better understanding about what is happening in the population, and that would also focus our healthcare needs to such population.
Thanks, Mika. We have another audience question from Sylvia. In terms of validating medical claims for patients with gender reassignment procedures, Did you find any issues in aligning the gender code after procedures in the medical claims with the member eligibility file? For example, were there instances of conflicts between the gender code and claims and eligibility data, or any higher rate of unknown reported in eligibility due to lag in updating demographic information in the eligibility file? That's a mouthful.
Yes, and that's a great question, Sylvia. And there could be some. We didn't cross match our eligibility data pre and post gender affirming procedures. Like we did literature review, there was a lot of focus on gender affirming surgeries, but they were not looking into all types of services. And that's why this study, we had focused on more on the diagnosis part rather than on the procedure part to see what is the utilization, and if so, what if there is any trend change post any planning or policies changes happened in 2017 and 2021. So although we might have seen some changes, and that's why I think unknown race, although being Hispanic or non-Hispanic is such high in this population, maybe they are not identifying themselves. Gender dysphoria is a really big issue here with such population. So uh, definitely there might be some insights into it if we have to look on that aspect of the study.
Great, thank you. We have another question from Katie. Thanks for sharing this important study. I'd like to hear more about the concerns around ICD-10 codes, in particular, how that is impacting those seeking gender-affirming care and any efforts underway to address the concerns.
Um, Thank you, Katie, for the question. And this was one of the important discussions we had with our community partners. We were initially looking into the procedures, and since procedure codes have such a large list, we wanted to group them together so that the self-identification and the suppression does not comes into play. That's why we shifted our focus from procedures to ICD or a diagnosis code. We just wanted to group them so that we can see the utilization. Um, how means moving forward, what my understanding is, the more people become self-aware, and more payers are willing to provide such services, I think the number of claims in the member would increase considerably. And we are hoping that since commercial payers will come into play from 2023, the data would be considerably higher, because most of such population is takes care or is insured through commercial payers.
Thank you. One other question from Norm, and I kind of had a similar question. What advice do you have for data programs that are producing analysis on politically sensitive topics? What are some considerations you had to take into account?
The first and foremost, we were the self education is a must. We I had to do a lot of literature review, and like I mentioned, most of the focus were on the gender affirming surgeries rather than the holistic approach which gender affirming care takes into place. Like it has to be any services, support services, any hormonal therapy, all those should be included. Um, we do tend to reach out to multiple community partners in the institute who work on this field, so that our data releases, which are so public, should not be misconstrued or should not be taken into a negative sense. And the language and wording is very important in such kind of data releases. So we need to have a good discussion with such partners so that we don't offend any population or community. So yes, my suggestion is do a lot of community outreach before jumping into the project.
All right, thank you. I have one last question. Why did you choose to focus the population on youth and young adults only?
Like I mentioned, Kristen, gender dysphoria is a big concern in such population. And with my literature review, we saw that youth and young adults are more prone to substance abuse, mental health, or suicide rates. And that's why our main focus was to see if there is a difference between uh, under a parental care, which is 17 years or younger, and post when they become independent, and see the trend if this is changing across board or not. And as you can see in the analysis, that there is a stark difference. People tend to take up a more stance towards their own gender identity, and they do reach out to providers, and one of the most commonality was they were thinking about such kind of care since long ago, since they were child, and that's why young adults are, we see a higher increase in utilization of such procedures and care.
All right. All right. Thank you, Miga. In the interest of time, let's move on to our last presenter, Jessica Little, who is the Vice President of Business Development and Programs at Civitas Networks for Health. Jessica will be presenting on advancing health equity through standardization of SDOH data sharing, and I'll turn it over to Jessica now.
Hi, good afternoon. I'm Jessica Little, Vice President of Business Development and Programs with Civitas Networks for Health, and I'm here today on behalf of both Civitas and our partners at the Gravity Project to share how we're working together to advance health equity through the standardization of social determinants of health data sharing. So I'll share a bit of background on both Civitas and Gravity, and really want to talk about why this work is important, why it's important to standardize SDOH data. I'll share what we're doing to support local level efforts, and then finally wrap up with how this work can support the advancement of health equity. So a bit about Civitas Networks for Health. Civitas is a mission and member-driven organization. We represent over 170 organizational members that you see represented here in the outer blue ring. Our members include health information and community information exchanges, community health improvement organizations, quality improvement organizations, many all-payer claims databases, vendors and technology partners, and other national collaboratives and associations such as NADA. So grateful to be here. Our members are diverse, right? There's a lot of different organizational types represented here. And one of the things they have in common is the fact that they work across different sectors and they work with many different stakeholders within the healthcare setting to use data to drive health improvement in the regions that they serve. So you see in the inner white ring, healthcare, health systems, Medicaid, public health, payers, community-based organizations, and more. So we recognize the critical importance of cross-sector collaboration and data-driven health improvement. So in addition to supporting our members through a variety of different networking and benefits, we also lead cross-regional projects through grant-funded initiatives. So we support local communities through the expertise and partnerships of our members and other partners with implementation and education, resource sharing, community building, health data research and evaluation. And we'll share more about how we're doing that with the Gravity in just a moment. So a little bit about Gravity Project. You may be aware Gravity is a member-led open collaborative that's working to develop consensus-driven and open source data standards to support how social determinants of health data is collected, used, and exchanged. There are a few different work streams across Gravity that enable this work. One is terminology. So the work stream that's really defining how we're talking about things like homelessness and housing insecurity, food insecurity, transportation challenges. And then with those defined terms, how are they coded? And once they're coded, the technical work stream is really supporting resources and training on how those coded value sets can then be exchanged through HL7 FHIR. And then, of course, we have these great standards that have been developed by Gravity. We need to test implementation, and we're doing that through a variety of different pilot programs. So why is this work important? Why is SDOH data standardization needed? You've all seen the schematic, right? We know that 80% of patient outcomes are predicted by social factors and only 20% by medical or clinical factors. And so with that increased knowledge has come an increased screening for social risk factors. Now, on one hand, that's fantastic. There's knowledge within clinical settings and community settings that these screenings need to occur, but they're not being done consistently within clinical settings, nonetheless across different types of care settings. And so when this data is being captured in different ways by different entities, it's leading to more data that's not interoperable. We can't exchange that data. And this can also increase provider burden for needing to capture and recapture this information over and over, and leading to patient mistrust. So this is vulnerable information that patients are providing if they're insecure when it comes to housing or transportation or food. And so asking them repeatedly when they're going to different providers, both within clinical settings and across care settings, is going to lead to mistrust and is leading to mistrust today. So it's critically important that we start to standardize how it's done and exchange that data so patients do not need to be asked the same questions multiple times. So Civitas and Gravity have come together with generous funding from the Robert Wood Johnson Foundation. We've been working over about 11 months to support implementation of SDOH standards in communities. So currently we're working in New York State, an initiative led by Bronx Rio, which is the health information exchange that supports the Bronx. And they are leading an effort pulling together 6 different health information exchanges across the state to identify how they can standardize the collection of screening data with an eye towards future assessment and exchange of that data. The University of Colorado Hospital is really struggling with limited resources when it comes to case management and ability to make referrals. So they are looking to standardize how they're collecting this data and get the data so that they can make the most of the limited resources that they have, that they can appropriately refer patients, and that they can advocate for resources in the community to support those patients. My Health Access is the statewide health information exchange in Oklahoma, and they are working to support how screening and data is exchanged across various settings with a goal to implement standardized screening across every care setting in Oklahoma. And then finally, in Pima County, Arizona, the county public health department is working with a Southwest tribe to initiate social care data exchange within their communicable disease surveillance system so they can provide the tribe with information about their community health, which can support policy and practices to advance the health of their communities. And so I share these 4 examples in thinking about health equity because, yes, we are supporting standards that have been developed and how those standards are implemented. But you can see these communities are diverse. Right? There's nothing standard about how this work is getting done in these communities. And so it's really critical that we're meeting communities where they're at, that we recognize the impacts of local partnerships, of local policy, so that we can truly start to advance and progress both within these regions and then curate and create tools and resources that we can share to other sites that are working to do this critically important work. And so how is this advancing health equity? I'm sure you've seen this definition over and over. Health equity is the state in which everyone has a fair and just opportunity to attain their highest level of health. And so when we think about that, and I've highlighted the word everyone, recognizing that everybody has different barriers. And if we don't know what those barriers are, we're not going to provide individuals and communities with opportunities that are fair and just. And so we need to, at the individual level, identify what are those social risk factors, and we need to aggregate that information that can be used to inform public health, that can inform local, state, and federal policymakers to start to implement programs and policies that can support not only individuals on a day-to-day basis, but that can support communities, that can support states. And so I'm just really proud to be part of this work. I'm grateful to our partners at the Gravity Project and to our team here at Civitas for working to advance this. And thank you to NATO and all of your partners for bringing us together today. If you have any questions, please reach out to me. I'm happy to work with you directly or to connect you to one of our subject matter experts that's working really on the grounds to advance this critical work. And thank you for taking the time.
Thank you, Jessica, for sharing with us the valuable work being done by Civitas and the Gravity Project. As a reminder, people can add questions to the chat, but I have a few of my own to start. What What do you see as the biggest challenge in being able to standardize SDOH data across care settings?
Yeah, thanks, Kristen, and thanks for having me today. Yeah, the challenge question is a loaded one, right? There are many challenges. One, as I alluded to in the presentation, is the process within the different care settings. Just looking at the clinical care setting alone, providers are burdened by the number of systems that they need to enter information into or retrieve information from. They are burdened by multiple different assessment tools. And so for a lot of providers, adding another layer and another tool, or in many instances, a different system in which they're capturing SDOH related data is really increasing provider burden and therefore reducing compliance with providers. The challenges with patient mistrust and not having adequate training for the various types of providers, both in clinical and non-clinical settings, that are collecting this sensitive information. Oftentimes patients don't want to report on this information, which is highly sensitive. And so if we can't collect the information, it's going to become increasingly challenging to exchange. So those are just a couple. Policies can be both a barrier, but can also help support this work. And those policies vary from state to state and region to region. And so, that's part of the work that we're doing, is really learning from these organizations and these pilots that are working to implement, so that we can collect the information and share these challenges with policymakers and others to help reduce the burden all across the board.
Thank you. I see that we have some chats from the audience. From Valerie, are there any opportunities to incorporate protective factors into analyses, strengths focused?
Not sure I fully understand Valerie's question.
Let's go to Norm's question. When looking at SDOH, do you think of this as primarily an issue for people in poverty, or is it also relevant to people with higher incomes?
Yeah, really great question, Norm. I was actually at a conference in DC just a couple of days ago, and we were having this conversation. And I think there is a perception or an assumption that this information and some of these challenges only are relevant to people of lower income, but they really do span the board. And it's critical that we have the data to further understand when individuals are being challenged with these circumstances. The other thing that standardized data collection can really help understand is whether or not some of these situations are permanent or temporary, which is why the details of the gravity standards are so important. How do we define homelessness versus housing insecure, right? Is the individual in a temporary situation, or are they in a long-term situation that we need to address? Because that's going to impact the referrals and the care plan or the treatment plan for that individual. So really great question. It's, it really does impact individuals across various income brackets. So thanks for the question, Norm.
I had another question. What types of tools and resources for SDOH standardization are you beginning to curate based on your work with your 4 pilot sites?
Sure, thanks, Kristen. So Gravity Project has developed a number of resources to support implementers that were in existence prior to our partnership. And what we've looked to do throughout the piloting is to test some of those resources with the pilot sites, to test some of those resources with community-based organizations and social service organizations, and refine and make updates and improve existing resources before we start creating new resources. I can chat in the link here in a second, but many of the resources are compiled on the Gravity Project Confluence page. But it's things like descriptions of the coded value sets and helping with understanding of how to use various screening tools and how to start to look at the various aspects of coding when it comes to SDOH data. So I can share that link so folks can have access.
Thank you. That'd be great. All right. This was our third and final presentation of the session, and so now we have the benefit of being able to bring all of our presenters back on the screen for some audience questions if there are any. But I can start with a few of my own if there aren't any audience questions. One, we can kind of go around, maybe starting with the first presenters, but how do you hope the states that you're working with will use your respective reports and findings going forward generally, and more specifically to advance health equity? I know some of you touched on this a little bit in your presentations, but kind of just a summary. Starting with maybe Amy and Simon.
Sure. Yeah, I can kick it off. Well, I hope that some of our findings will shine a light on certain unmet behavioral health needs in Washington. I mean, we saw in one of our slides that Amy presented, the percent of members with mental health conditions has continued to rise from 2017 to 2022. So presumably that's an occurrence in other states and worth looking into. And states are always interested in cost information. And so when that data becomes available for our follow-up study, I'm sure it'll be really useful for other agencies within the state, policymakers with legislative session just around the corner, as well as other states concerned with growing healthcare costs.
Thanks. Amy, do you have anything to add? I wanted to note that one of your findings was that mental health claims are more likely to be billed by out-of-network providers than non-mental health claims, which would indicate some behavioral health network adequacy issues. Do you think your study could be used by Washington to identify and address some of these network adequacy concerns?
Yeah, I think that that's kind of the goal of one of the goals of the study was to identify that. And Simon and we also work with Jane Byer at the Office of Insurance Commissioner, so they're tightly connected there on sort of how they can use these findings. But yeah, our goal is to get the data out there, have it be correct, and have it in a way that legislators and the public and other policymakers can use it and hopefully do something, make change with it.
Great, thank you. Mika, do you have anything to add about your presentation and how you hope Colorado will use it?
I think the more, as and when, since from 2023, as I mentioned, we would get more claims from commercial payer. It becomes a compulsory add-on to their claims. We would see an increasing trend, and once we have a good trend, I think there should be some more policies and plannings to be done on the healthcare needs of such population. And health equity, as you mentioned, Kristen, it's a broad spectrum. And although Colorado is leading in most of the health equity work, and Civic is also pioneered in doing such kind of work, like we have our own public reporting on social determinants of health, gender affirming care, as such, and we do a lot of health equity or telehealth equity work with different state agencies like DOI, which is Division of Insurance, or with the HIPAA team. So I think we are moving in a right direction, and the more people get exposed to such kind of reports, the more we make a better informed decisions and discussions along the path.
Thank you. And Jessica, do you have anything to add to this question?
I don't at this time, Kristen.
Okay. I see a question here. The audience chat is pretty active, but Mika, there's one question for you. Did you find any, this is from Anne, did you find any association between the ICD-10 code issues and the gender affirming care services allowed by the state of Colorado, such as state policy for such services?
Not really. And like I mentioned, that the procedures means with my literature review, the people or the research was more focused on surgery part of it. And since gender affirming care is such a large, broad spectrum of care, and such procedures could not be only linked with the gender affirming. It could be linked with any other care like behavioral health or substance abuse as such. So that's why we focused on ICD-10, and we wanted to see if we are pulling as many claims, not just the procedures, to see if they are encompassing all types of procedures. And we didn't find any difference as such. Uh, but hopefully in future, once we have more claims, we might see some variations here and there.
All right. This kind of leads to my next question about kind of what's next for your projects in 2024. Simon, Amy, Miga, will these be like, I know, Amy, your follow-up study is still in progress. Is that going to continue into 2024? Are your analyses going to, be refreshed annually to look at trends? Jessica, will there be another phase of pilot sites? Maybe we can start with Simon and Amy again.
Sure. So our timeline is we're trying to get this study done by December. So we're working really hard this month to kind of finish that up and get it out in time for legislative session in Washington. We're really hoping to do more work in this area. I think this is under a grant, so I don't think there's actually right now a plan to continue to do this every year, but we'd love to do this with additional states and kind of looking for kind of other collaborators on these issues.
Excellent. And Mika?
We don't have any plans for renewing this 2024, but I would definitely love to do it. As I mentioned, 2023 we would have more commercial claims because the policy has been made. And this was one of the requests we have gotten from one of the news reporter, and we had published as our public data release. So if some request comes, the more eyes this report gets, more people want to know about it. We would love to do another analysis on it.
Thank you. And Jessica?
Yes, our goal is to continue to support pilots into 2024. That said, our current funding does end at the end of this year, and we are proactively pursuing additional grants and contracts to support pilot work, resource development, and co-design sessions where we're bringing community participants to the table to really help shape some of the resources and concepts behind this work.
All right. Thank you. Are there any other final thoughts from our presenters before we wrap up? Well, I wanted to thank Amy, Simon, Miga, and Jessica for sharing your time and expertise with all of us today. Thanks to all of the folks who are joining us in the audience. Thanks for taking the time out of your day to listen and participate with these great presenters. And I hope you all found some information that you can use and apply to the work that you're doing. This concludes our session, but up next on the conference schedule, we have some health data deep dives revolving around using census data, the Master Person Index, cost growth benchmarking, and hospital discharge data. And if you're interested in any of those subjects, please join the room you're most interested in for a chance to have a deeper conversation about these topics with some experts. Thank you.
Thanks, Kristen.
Thanks, everyone.
Thank you.